Well, welcome to the monthly town hall. Thank you all so much for attending. We're really excited to have our guest speaker here this evening. So we have a special guest who's originally from Illinois and has practiced in Illinois before, however, is currently practicing in Iowa. So I'm happy and privileged to introduce Dr. Wendy Mobley Buckstein, who is an associate professor of pharmacy practice in the College of Pharmacy and Health Sciences at Drake University. She received her Doctor of Pharmacy degree from Drake in 1999 and is a certified diabetes care and education.
And the next question is, which of the following strategies should be used when?
She's also board certified in ambulatory care and certified health and wellness coach. She teaches a medication management elective, co-teaches the advanced diabetes care elective, and coordinates the intermediate pharmacy skills and applications to lecture and lab. She teaches in the pharmacy skills and applications course series and the self-care and non-prescription products course, both team taught courses. Wendy maintains a clinical practice at Primary Healthcare Eastside Clinic, where she precepts third and fourth year student pharmacists, focusing on interprofessional ambulatory care and diabetes as a specialty practice. Her areas of interest in practice and scholarship are diabetes, medication management services, and community education. She is the co-president and advocacy lead for the Iowa chapter of the American Association of Diabetes Educators Coordinating Body, American Pharmacists Association Academy of Pharmacy Practice and Management president, an active member of the Association of Diabetes Care and Education Specialists, where she sits on the Professional Practice Committee and Advocacy Committee, and Iowa Pharmacy Association, where she is a member of the Education Advisory Committee and the Policy Committee on Public Affairs. So lots of experience to bring here tonight to talk about this evening's topic about the use of person first language in chronic disease. And we're, again, very happy that she's here with us tonight. I'm going to turn it over to you, Wendy.
Thanks, Jenny. Well, good evening, everyone. I told Jenny and Jamie earlier, I currently have 2 dogs, 3 kids, a pharmacy student who's living in my basement at my house. So I'm hoping and praying that everything goes well and that I don't get any interruptions. But just so you know, occasionally I might have an extra head stick into the frame tonight. So thank you so much for inviting me to speak. Person first language has been something that's been very important to me, both as part of the IPhA APPM presidency. Last year, our diabetes management SIG brought forth a new business item that was passed in our House of Delegates regarding person first language, as well as very near and dear to my heart, both ADCES and ADA collaborated and published a paper in 2017 talking about the use of person first language, specifically in diabetes. But I think that as I titled the presentation for tonight, I think it really focuses more on just thinking about it in all chronic disease. So I have no disclosures or conflicts of interest to tell you about tonight. And then these are the objectives. The technician objectives as well as the pharmacist objectives do not change, they're the same. So I'd like for you to be able to differentiate between person-first language and disease-centered language, or I may also refer to it as deficit-based language. So those are mingled terms. And then create a narrative documentation for a patient interaction. So we'll talk a lot about how are you going to document your interactions with patients, and really thinking about the words and being mindful about the words that you're using when you document. And then finally, recall resources to inform healthcare professionals about person first language. So our first test your knowledge question is true or false. The following documentation would be considered person first language. Joe has been diabetic for 20 plus years. He currently takes Lantus 65 units daily and Humalog 20 units with each meal. So think about that question because we're going to visit that at the end. And then the second question, which of the following sentences would be found in documentation that is considered to be person-first language? Is it A, Mary reports struggling to remember her medication 2 nights per week? B, Joe is a 46-year-old male with type 2 diabetes for 20 years. C, Nancy states that she eats half of the Hy-Vee Chinese 2 entree meal on Friday nights. Or D, all of the above, or E, only A and B. So again, think about that, mull it over while we're talking about person-first language tonight, and we'll come back to that at the end. Again, as I stated before, this was the statement that we passed in the House of Delegates in March of 2021. APHA encourages the use of people-first language in written and oral forms of communication. And so I think that it's really important to think about, again, how we're going to do that, not only in our documentation, but also with our interactions with patients. So as Jenny told you at the beginning of this, I am a certified health and wellness coach. And so a lot of the things that I'll talk about or talk with you about tonight, I utilize a lot of health coaching techniques when I'm interacting with patients. And so I can tell you that that is one way that I've been able to incorporate more person-first language into my practice. So many of you have probably seen this before. People will forget what you said, people will forget what you did, but people will never forget how you made them feel. And quite honestly, I feel that that is really where person-first language comes from, is because when you talk with someone about a disease or disorder that's affecting them, referring to them as someone with that disease is much better because they are a person, they're an individual, and it's really important for them to be identified as, or like myself, I identify as Wendy. I don't identify as being an asthmatic, or any one of my patients, thinking about them, many of them don't identify as being a diabetic. They identify as Mary, a person with diabetes. So thinking about how we're talking with our patients and how ultimately we're making them feel about themselves when we're talking to them about their disease or disorder. So we're going to talk first about just identifying what is person-first language, what is disease-centered or deficit-based language, and then how do we move from utilizing one type to another. So as I was preparing for this presentation, I ran across this article by Dr. Crocker, and she had some really profound statements that I thought were just really interesting. And so this was one that I pulled out. Language has the ability to change how we think and how we view the world. And so if we think about the way that we are saying things, the intentional way that we word things, we're definitely going to help our patients that we're helping view how they think about their disease state and how they view the world around them differently if we're utilizing person-first language. So disease-centered language is just exactly what it sounds like. It's defining the person by their disease or their disorder that they have been diagnosed with. So for instance, like I said, my specialty is diabetes. So talking about someone who's diabetic. Or I have asthma. I've had asthma since I was 2. I don't identify as being an asthmatic. I run 5K almost every morning. So, I don't like to be defined as an asthmatic, but I do have asthma. So I think that it's important to think about how people want to be identified as well. So an example of how someone might utilize disease-centered language is listed here below. And I'll just read it out to you. And you can feel how someone who might read this would feel if they were to see this about themselves. So Drew is an addict that began abusing drugs and alcohol around 12 years old. Drew was manipulative and a real party animal. The addict hit rock bottom and even cut their wrists. The cutter was out of control and placed in rehab at age 13. Drew's mother was unfit, and so the addict emancipated themselves at age 14 from her and abused the system. when I hear that, like, that's really hard for me to hear, because I think of myself, if that were me and I was reading my patient portal and I read that about myself, I would think, man, my provider thinks I'm a terrible person. And then I would have to think to myself, do I identify as that kind of person that my provider has talked about? So I think that it's really important for us to think about how we're writing things, how we're stating things when we're talking with someone. And this is just an example of how the current and maybe past medical model has really identified how we talk to patients and talk about patients. And so that brings me to this, again, another statement that I found in Dr. Crocker's paper was how healthcare practitioners communicate can both positively and negatively affect their patients' health outcomes in a way that is not directly linked to the medical treatment that they provide. So again, thinking about the way that you talk to someone and how that may positively or negatively affect how they take care of themselves. So when we talk about person first language, this is the idea, again, of putting that person first and their diagnosis second. And when we looked at the ADA and the ADCES paper that was put out in 2017, there were several pieces that were indicated there. Words that indicate awareness, a sense of dignity and positive attitude toward persons with a disability or disease, where we place emphasis on the person rather than the disease or the disability. And so again, really trying to make sure that we're talking with that person and we are understanding the way that they want to be identified. So this is an example, again, of person first language, and I'll just read it to you. Barry is a person that has substance use disorder. Barry is a resourceful and talented actor that began their career at 11 months old. Their mother took them to many parties, and Barry was exposed to a substance at a young age. After a couple of years, Barry couldn't successfully cope with their substance use disorder and needed treatment, which they received. Barry's mother was experiencing barriers to successful parenting. Barry decided to emancipate themselves at age 14, as that decision seemed to be self-advocating for their best choice for recovery. So again, when you read this one, this is a much better, there are a few things in here that are a little, I'm a little, probably not something that I might say, I guess, but definitely better. And if I were the patient and I were reading this about myself, I definitely wouldn't feel as bad as perhaps the patient before that we experienced. So just to give you some background on where person first language has come, this work began in 1974, and it started with what was called the People First movement, and was really founded out of individuals with disabilities who were tired of being stigmatized for having a disability, either physical or mental disability. And so several pieces of work came out of this as well. So the Education for All Handicapped Children Act, that came out of it. Also, the Federal Developmentally Disabled Assistance and Bill of Rights Act came out of that. Subsequently, in 2010, there was a law called Rosa's Law, and it was called the Spread the Word to End the Word campaign. But to give you a little background on that, Rosa's Law was a little girl who was identified as being, quote, quote, mentally retarded in her school. And her sister went before the school board and asked for those labels to be taken off of her because she was being labeled in such a way in her school that it was making her actually not really try with any of the therapy that she was getting because people were just stigmatizing her as having that mental challenge. And so at that time, Rosa's Law was passed and it became a federal law where they went back and they took all of words related to the diagnosis of mental retardation and those kinds of words out of legislation and tried to move to a more person first language in different bills. And then we have the American Disabilities Association. And so that, if you've heard of the ADA, diabetes is part of the American Disabilities Act now that we have. And so a lot of this work all started in the 70s and has just come forward. In 1992, the American Psychological Association led the movement to use person-first language in mental health. And so that's where we're seeing a lot of the clinical evidence coming forward now is out of the mental health space. In 2001, the Institute of Medicine report that came out, it was called The Quality Chasm. On page 6 of that report, they talk about utilizing person-first language and described it as care that is respectful of and responsive to individual patient preferences, needs, and values, and that helps guide patient values in the clinical decisions. So utilizing the patient's values and their wants and desires in helping with going forward to help them with their treatment. So when we really think about all of the work that has been done thus far on getting us to be able to use person-first language, we have to start thinking about all of the different things that we currently utilize in our daily practices. And so one area I think is really important to think about is technology. So I work in an ambulatory care clinic. We are not affiliated with a health system. And so we utilize a different electronic health record than most of the health systems in Des Moines. And so I think about when you have that health record, now we have this patient portal, and the patient can go in and they can read any of the notes that we put into their patient portal. So if they come and see me for diabetes education or management of their medications for diabetes today, they're going to see the note that I write. And so I often think about, okay, well, you know, Mary told me that she's missing 2 doses of her medication every week. How am I going to write that? Because I can tell you when we talk with our students about it, we're like, oh, that person is non-compliant or they're non-adherent. But that's definitely not something that I want to put into my note in those words. And so for me, I might write, Mary struggles to remember to take her medications at least 2 times a week. And so she stated that to me. That was something that she gave me. It was subjective information, but information that she gave me. And so trying to make sure that I am putting it in a way that she talked about. Well, I fall asleep in my chair and I just forget to take that nighttime dose. You know, those kinds of things. I will actually write those types of things in my note rather than saying that she's just non-compliant with her medications. I think it's very important for us to think about the fact that people are accessing those patient portals. They are looking at that information. And so really thinking about that connection between the health record that we're utilizing in our practices and then what the patient is actually seeing. So being very mindful of the language that we're using when we're documenting our interactions with those individuals. When we think about those patient interactions and creating that documentation, it's best for us to use strength-based languages. So thinking about being opposite of something that's deficit approach. So emphasizing what the people know and what they can do. So really focusing on those strengths, empowering them to take more control over their diagnosis and making sure that they're doing the right things to be well managed with their diagnosis or healing, if that's possible from the different diagnosis or disorder that they may have. So an example here, Lee takes her insulin 50% of the time because of cost concerns. I think that this is really good. Again, I'm not saying Lee's non-adherent or non-compliant. I'm just stating that she tells me that she's taking her insulin only 50% of the time because she can't afford it. When we look at the recommendations that came out of the collaboration paper between the ADCES and the American Diabetes Association, they came out with 5 strong recommendations. And those recommendations include using language that is neutral, non-judgmental, based on facts, actions, or physiology/biology. Using language that is free from stigma. Using language that is strengths-based, respectful, inclusive, and imparts hope. Using language that fosters collaboration between patients and providers. And using language that is person-centered. So again, you may hear me throughout the evening, I've talked about patients versus person. Again, that's very subjective as to how an individual wants to be identified. I think, when we're talking amongst ourselves, we typically talk about patients because that's who the individuals are that we're serving, is they're patients in my clinic. But sometimes, individuals also see that as stigma because they see that as being someone who has something wrong with them. So they may not want to be identified as a patient as well. So that brings us to the end of the information that I have to share with you, but I'm willing to take questions. I definitely want to offer time for you to ask questions. Again, like I said, this is a work in progress for everyone. I still find myself, even though I'm a strong advocate for person-first language, there are times I still find myself writing something and going, oh, that sounds terrible. I shouldn't write it that way. And then I go back and I have to, rethink how I want to state something. So I don't know, Jenny, in the past, do you have people raise their hand or come off mute, or how do you want to handle questions? The chat box, maybe?
I think what some people are comfortable doing it either way. So some will raise their hands and unmute, and others will type in the chat. So
Okay.
We'll keep an eye out for either method.
Okay. I see your hand up, Laura.
Hey, thanks, Wendy, so much. This is a very interesting topic that I think is really important. Also giving, trying to be as objective as possible when talking to patients, and also empowering them that they are not their diseases. Do you or Jenny have an example of something recently, just so I can understand like what you may have maybe put in the past, and then just what sort of clicked in your head, like, oh, I should change it to that? Sorry to put you both on the spot.
Well, that's okay. I think, I still encounter with some of my colleagues, we have a diabetes concentration here at Drake. And so even some of the colleagues that come in and teach within the concentration are still referring to patients as diabetics. And for me, that's like nails on a chalkboard. I'm like, no, they are people. They are people with diabetes, and, but like today we had a gentleman come in who has a schizoaffective disorder. And the students, I was telling Jenny, this is the first week of our block 8 of 9. And so the students come in and I was like, okay, y'all are going to go see him, and they're like, what? And I'm like, oh yeah, it's going to be fine. And they come back and they're like, he would just shut us down. Like he didn't want to talk about any of that stuff. Like, how do we put that in a note? I'm like, well, what was it exactly that he didn't want to talk about, and so we kind of talked more about that, and they're like, well, he doesn't want to change how he's eating at all. He has like 8 or 9 meals a day. And I was like, well, we can't judge him. Can't judge him for having 8 or 9 meals a day. And then when you start looking at the medications he's on several medications for his mental health disorder that cause him to probably be very hungry. And so then I said, well, we need to really talk to him about the type of food that he's eating and perhaps the quantity of food that he's eating. But 8 or 9 meals a day, maybe that's what it takes for him to feel satisfied. But we need to make sure that we're talking to him about different things. So we've also figured out that this particular person is going to need very small, very focused time with us on little things and making small incremental changes rather than trying to kind of do the whole gamut of a 60-minute appointment and run through everything that we might try and run through with someone who's newly diagnosed with diabetes. Does that help?
Totally, because you took it a step further, and I thought you were just going to say they referred to him as a schizophrenic, and you said, no, schizoaffective disorder, but actually it's many layers deeper than that when you're summarizing that patient interaction. So actually that was the perfect example. Thank you.
Yeah, you're welcome. I see, Harry, you have your hand up.
Yeah, thank you very much for the talk. I really appreciate kind of that perspective as far as not only talking with patients, but talking about patients and the potential judgment that comes from how we describe patients. I feel like a core of that is related around identity. And so as you mentioned, I'm not an asthmatic, I'm a person with asthma.
Right.
I feel that can also extend to even potential racial biases or sexual discrimination, that the way that you phrase it is how people can interpret it. And so I just wanted to at least make that comment that I really appreciate that as a topic.
Yes, and I would go a step further in that when we created the policy that was passed at IPHA, that was definitely a comment that we received during different webinars. And I believe a comment that happened during the House was that person first language and identity-based language are things that we need to really be considering, and that it goes farther than just chronic disease, that it can also, I would say, scale some of the different social issues that we are also facing, such as racial disparities, gender identity, those types of things.
For sure. And I feel like, especially in the, more, I'm trying to lead to like LGBT kind of expression, saying, or at least describing a patient who has sex with men as gay or as in, LGBT or something like that. The way you phrase it can have different connotations based on how other healthcare providers can read it, and therefore eventually deter their optimal healthcare outcome.
Absolutely. And I think it's important too to ask the patient how they prefer to be identified as well. And sometimes, even though that may mean something different to every single person who reads it, you can say, Joe identifies as a man who has sex with other men, blah, 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 blah. So then you're able to put that into perspective so that anyone who's reading that understands what that means.
Wendy, got a quick follow-up on this, just as looking at it from a policy knowledge, just extending it from a policy point of view, but also looking at it from a legal point of view, especially now that we have patients who have more rights to their charts than they ever have before. And especially with using a person first approach, it's to be able to make things more non-judgmental, but you said that, but we have to describe facts. Where does the legal implications come through when you need to put something into the record, but the patient's not going to agree or object? Because like you used in your one example, because you have multiple different practitioners within the team, and they may not all be following as intimately in the conversations and appointments as you are with the patient. But your example with the one patient who has 8 meals a day, well, that's a critical fact that needs to be documented somewhere. But in the patient way, you want to make it non-judgmental, but there could be legal ramifications if this type of language is not appropriately documented, because at the end of the day, these are still legal documents, and we have to describe patients in a medical and legal aspect, regardless of where feelings or perceptions may be. But we have to address all those issues at the same time.
And I do agree with you with that. And I would say that especially when you feel that it's going to be detrimental to the patient's health, that it's possibly not going to come across in a way that it needs to, or you know, in the example of that patient, we wrote in there, patient states he has 8 or 9 meals a day. Like we put that in there. It's a fact. You know, and so if, you know, if it's something like that where there could be some sort of legal ramification, there's no right or wrong to the way that we're doing things. And you know, for instance, like my BMI, you know, okay, my BMI used to be 40. Okay. And so I was considered morbidly obese, and it was in every piece of whatever you could find, right? I have worked solidly for 2 years to get that down. My BMI is 27 now. Thank you very much. But I no longer have that stigma behind, you know, that part of me. But it was in there, and it had to be in there, because if I had a heart attack, or I had a stroke, or I had, you know, something else, that needed to be documented. And so there are some things that have to be documented. And I'll be honest with you, I don't document those kinds of things because I don't need to. Those are being documented by the medical provider, right? I'm documenting on the diabetes related type of things. And so, but when it comes down to it, when, like, as far as diabetes is concerned, if that person is, you know, they're not taking their insulin, I'm putting in there, they're not taking their insulin. I'm not saying that they're not compliant. I'm still saying though that they aren't taking their insulin. I'm just wording it in a way that when they read it, it's, you know, it's not as inflammatory as me saying that they are non-adherent or non-compliant. So I'm still putting the information in there. I'm just trying to word it in a nicer way.
Excellent. See, I knew you were going to hit this. There's no problem. I appreciate it. And you got a couple good questions in the chat here.
Oh,
we got
okay.
one that says, from James, that did you say you avoided the use of the term patient?
So we don't avoid the use, but there are some individuals who don't like to be called a patient because it implies that there's something wrong with them or that they're sick. And so sometimes they want to be called, you know, a person with diabetes, or a person with asthma, or a person with cancer, or whatever it happens to be. But typically there are some individuals that don't like to be called a patient because it implies that they're sick. But again, I would say when I'm talking with other providers in my clinic, we typically refer to people as patients. But perhaps when I'm talking to the person themselves, I might not refer to them as a patient. Does that make sense?
No,
Go ahead.
Go ahead, James.
no, it doesn't make sense.
Okay. A lot of times I'll ask the person if it's okay for me to call them a patient. Especially if they kind of look at me funny, like, I'm not a patient, I'm not sick. I get a lot of people that come in to see me for high cholesterol, for instance. And they'll say, well, I don't need to take medicine. I don't feel bad. There's nothing wrong with me. I can't. I'm like, well, you know, we take your blood, and, you know, you have a high level of fat in your blood. And so then I'll talk to them about the cholesterol and all the different pieces of the cholesterol. So this is your total cholesterol. This is what your LDL or your bad cholesterol was. This is your HDL and what your good cholesterol is. This is what your triglycerides are. You know, sometimes I have to explain what those things are. And so I think it's important to, you know, to talk about, you know, all of those things. But then sometimes individuals just, they don't feel sick. So they don't feel like they're really a patient. And coming into a doctor's office, usually that's okay. But I think sometimes when people are coming into a pharmacy, they don't see themselves as a patient. They see themselves as a customer. And perhaps we need to change that narrative too, right? Because we are healthcare providers, and no matter what part of pharmacy you come into, you're still coming into a healthcare entity. But that's, you know, part of the reason why. And again, that's that, I guess, definition of patient versus person is still coming from the American Psychological Association definition.
Thank you.
One of the speakers about person first language who has diabetes themselves had talked about that patient versus person. And for them personally, the way they described it was that they did not want to be referred to as a patient outside of being treated in the medical facility. So like, it's fine, you can call me a patient if you're my provider, you're taking care of me in this setting. But when I leave, I am a person, and yes, I have diabetes, but I don't want other people talking about me outside of that setting as a patient with diabetes. I'm a person with diabetes unless I'm being treated at that moment by healthcare professionals. I don't know if that helps or not, but I just wanted to put that in.
Now, Wendy, we have one more question in the chat, and then we can get to the review questions.
Sure.
How widely across the healthcare spectrum is person first being included in curriculums?
So I would tell you, at least in our college, we're trying to include it as much as possible. And like I said, it's a work in progress because we still have instructors, professors within the college that are not using person first language. So it's a work in progress. But since 1992, the American Psychological Association has been trying to kind of mainstream it in medical curriculum, through mental health. And so I think that we'll see more and more mainstream of this as time goes on. All right, on with the questions here. So question number 1, true or false? Joe has been a diabetic for 20 plus years. He currently takes 65 units daily and Humalog 20 units with each meal. So that is false. The use of the disease as a descriptor word is not person first. So this would be considered disease-centered language or deficit-based language and should be reserved when talking about a complication of the disease or disorder. So a better way to have said this in the documentation would be Joe is a person with diabetes for 20 plus years. The second question was, which of the following sentences would be found in documentation that's considered to be person first language? A, Mary reports struggling to remember her medication 2 nights per week. B, Joe is a 46-year-old man with type 2 diabetes for 20 years. C, Nancy states that she eats half of the Hy-Vee Chinese 2 entree meal on Friday nights. D, all of the above, or E, only A and B. And the answer to this one is D. I always tell students, if in doubt, answer all of the above. All of those are examples of appropriate ways to document information in person first language. It's objectively stated in accordance with person first language. And it's also prudent to discuss with the person if they prefer person first language or identity-based language. So identity-based language would be where someone wants to be referred to in relation to their disease. So for instance, a really good example of this is someone who's deaf. So they actually the deaf community likes to be identified as being deaf. And I thought that was really interesting when I was reading about it. So there was an article talking about person first versus identity first language and how there are some individuals or some communities that prefer to be identity first language versus person first. But again, making sure that you understand or you ask and be curious with each person to find out how they would like to be identified. So just quickly, some wrap-ups here. My take-home points: incorporating person-first language into your daily interactions and your practice, utilizing strengths-based language in your interactions with people and in your clinical documentation, educating colleagues and peers on the necessity of person-first language, and then utilizing resources that are available to continue to improve on your ability to put the person first when you're talking with them. So here are quite a few different references and resources. Number 5 is the paper that I was talking about that has come out from ADCES and ADA, the use of language in diabetes care and education. The lead author, Jane Dickinson, she's wonderful to listen to her speak. She just spoke at the ADA's Clinical Update Conference, as well as she's spoken at the ADCES annual meeting as well. But she's very passionate about person-first language. And so I think that this paper does a really good job of illustrating that. And then my contact info. But thank you again so much for having me, allowing me to talk to you about person-first language, and coming home and seeing some familiar faces in my Illinois pharmacy family.
Thank you very much, Wendy. I'm greatly appreciative of you being able to take time out this evening to help lead us through this important discussion, and one that will continue to help us as we continue to challenge ourselves to, right ourselves, as we need to be better for our patients each day. And before I forget and we switch gears, one, I put the link to the evaluation in the chat. You guys can start filling that out here shortly, and I'll give you your code here in a second, but I'm not quite there yet. But Wendy, since we do kind of have them all held captive till I give them the code, and as Academy President, is there anything from APHA that you would like to share with the group? Oh, you're muted. Wendy, you're muted.
Party foul. It happens almost daily for me. I don't think we have enough time for all of the things that I'd like to talk about, but we have 9 new business items coming forward in our House of Delegates. We had our second new business item webinar today. Some really great things. I don't know if you all have been talking about it in Illinois, but one of the new business items that I'm really excited about is about procurement strategies and patient steerage, and specifically brown bagging, white bagging, and clear bagging. So for those that are health system pharmacists, we have never in APHA's history passed a policy on specialty pharmacy. And so this will be the first one that we're, I don't know, we only had like a handful of comments on both new business item webinars on different things that they, wordsmithing type of things that were coming up. So I'm super excited about that. There are 2 diabetes new business items that are coming, having pharmacists recognized not only to be able to provide DPP, but also DSME without being in an accredited program. So having pharmacists recognized as a provider rather than a program billing for the pharmacist service. So I think both of those things are really exciting as well. I would like to, I guess it's kind of marching out the big elephant in the room, but there's been a lot of social media talk about people not wanting to go to Texas because of some of the social issues that have been happening in Texas legislation, specifically related to LGBTQ plus population and community. And so just as a reminder to everyone, the places that we go for our annual meetings are, those are decided years in advance, and contracts are signed. And so we had no idea 4 years ago when they decided to have the meeting in San Antonio that we would be, we'd be in the middle of these kind of issues that are going on there right now. And so I think it's important for everyone to know that we, as the Board of Trustees at APHA, which is I'm on the Board of Trustees, we recognize that. We are proactively making statements and letting individuals know that we don't condone the actions of the Texas Congress, and that this meeting is for pharmacists and about pharmacy. And we really want people to come for that reason, and not to think that we are, giving Texas money to come and have our meeting there, in light of all the things that are happening. But it's just really hard to pivot a large production like the annual meeting due to kind of some of the social things that are going on there. So I did want to address that because I think it's really important. I did not take to social media. I did not call out the person on Twitter who made the post. I decided it's probably better that I just not do that, but I do want to make sure that when I'm talking with my colleagues that y'all understand that we don't, we're definitely are aware of the things that are going on there. And if we could make changes, we definitely would. But at this point, there's a lot of money in contractual agreements that have already gone into the annual meeting.
And a lot of that was done pre-pandemic.
Yep. Yeah. So we're going to Arizona next year. We're going to Florida the year later. Hopefully, hopefully we'll know what's going on in those areas well before we go there.
All right. I do want to be respectful of your time, but we do have a couple of major topics that we've been getting a lot of questions on at the office that I want to make sure that we cover real quick and make sure that I'm actually getting that document. All right, here we go. So the biggest thing is on renewals. And just as a reminder, with the governor's budget address, he did put in there as a proposal for the next budget year for 2023 that he was going to waive license fees as part of a thank you for our work during COVID. So it's kind of tricky how it's working. So I put this bullet points together to kind of go through it here real quick. So for pharmacists, our renewals are extended to July 31st of this year, and your licenses already reflect that. So if you need to print out your new license, you can go through the portal and be able to do that. You should have received emails from the department recognizing giving you your username and your password. If you have troubles, your username is your license number, and you can always submit for a password reset. So you don't have a license fee for renewal. So you should be able just to process, and that's clicked over for the next 2 years. Pharmacies and technicians, you do have a fee for this year. And for pharmacies, that's both your licenses for your store and your controlled substance. Those have all been pushed to your extended renewal of May 31st. So going back up here to pharmacists really quick, the reason why pharmacists are in July is because for the governor's budget waiver, the license waiver to hit, it has to hit in the budget year, and that doesn't start till July 1. And so that's why pharmacists are in July, pharmacies and techs are in May 31st, and you do have a fee for this year. We did have to reach out to the department because earlier in the week, controlled substance licenses had not been moved forward to May 31st, and they are now. So pharmacies, please get on there and print out your new licenses and make sure that you have those at least temporarily sent over to your wholesaler, because you will need those licenses to be there between April 1 and May 31st, or at least until you get your brand new license for up to 2024. Again, technicians, you'll have your fees waived in 2023, so next year's renewal, because remember, techs are still on an annual renewal basis. And again, the fees are being spread out this way to help kind of spread out the monies through budget year of 23. And again, the one thing that we want to make sure, because we haven't made this more complicated enough, your CE deadlines did not extend. So you still have to have pharmacists, you have to have 30 hours by end of this month. Certified technicians, you got to have 20 hours by the end of this month. For this cycle, remember every renewal cycle, pharmacists, you have to have at least one of your 30 has to be in sexual harassment prevention. Certified technicians, you got to have 1 hour in sexual harassment prevention, 1 in pharmacy law, and 1 in patient safety. And of note, reminder, we've talked about the 1 hour for implicit bias training. That law did go into effect on January 1 of this year. but the department said many, many times, because we had them repeat it 20 times probably at least at the January Board of Pharmacy meeting, there are rules to put that that provision into enactment, and the enforcement won't happen until January 1 of 23. So that pushes it for our next renewal cycle. So if you've taken an implicit bias CE training between last year, the first part of this year, before March 31st of this year, great. You're going to have to do it again after April 1. So it counts for the next renewal cycle. And I saw that Randy said that he was already not assessed a fee on his renewal. That's great. Any questions on anyone on renewals? I know we've had a lot of questions, and I really wanted to kind of help break this out in the bullets for everybody. Does anyone have any questions on this before we go on to the next topic? All right. Lastly, face masks. As we know, Governor Pritzker issued an executive order on Monday that pulled back most of the mask requirements for the state. In situations, there are still some situations the state still requires for masks, and that's listed here in Section 2 of the executive order. And for all long-term care facilities, they still have to follow CDC guidance and IDPH guidance. And that means that face masks have to be used for anyone over the age of 2 or medically tolerant within the facility. Secondly, all individuals, regardless of vaccination status, shall continue to wear a face mask in the following areas. Where federally required, in transportation, methods of transportation, in congregate facilities or correctional facilities or homeless shelters, and number 4, in healthcare settings. So at first we thought it was going to be a complete pullback of the mask mandates, but then it quickly changed that healthcare settings were going to stay as they have. So again, you do need to make sure, because healthcare settings, as in previous definitions of previous executive orders, pharmacies are included in that definition of a healthcare setting. So your staff, you and your patients need to have masks on while they're in the pharmacy, because again, we're a healthcare facility, we're a professional facility. We need to make sure that we are protecting ourselves and our patients. There is a question. Yes, I agree with that. Yes, pharmacies are considered healthcare settings, but we haven't been recognized as healthcare providers. It's small steps, small steps. In addition to that, Rupesh asked a really good question. Have we sent anything from IPHA to officially thank Dr. ZK for her support of pharmacists? No, we have not. I've been actually drafting a letter that I was going to send on behalf of the association to the department, just as a note to Dr. ZK. Dr. ZK, as you know, has announced her resignation as the head of the Department of Public Health effective March 14th. So, you know, we're glad for her support for pharmacists during the pandemic. There was areas where we had some disagreements, and other areas outside of the pandemic issues, but overall she's been very supportive of the profession, and we've been able to accomplish a lot because of that support and a lot of the support of the other physicians and pharmacists that work for IDPH. So we're very glad for the opportunities that we've been able to have during the pandemic so far. And a lot of that we do have to give Dr. ZK a lot of credit for that. So we do thank her for her service, and I have to give it to her for helming that ship. That it was not an easy job to have for the last 2 years. I don't care who you are, or how long you've been in government. That was a tough position to be in on a day-to-day basis in front of the cameras, and we all know the stresses a couple of times that she's had with it, and greatly understandable. So just one last thing before we go. if for those of you that watched the State of the Union last night, there was some talk on there about pharmacies that related to healthcare. And as we all know, just because it's said in that podium does not mean it's going to happen, or it does not mean that it's going to happen very quickly. We already heard that the test to treat is not meaning all pharmacies. Surprise, surprise. And I'm really glad APHA came out last night immediately and was saying, then make us providers so we can do it, which is the right answer. But it does seem like it's going to be a lot of the pharmacies that have clinics, or pharmacies that have clinics in their vicinity. It was very, very disconcerting and sounding very disorganized. It sounds like, again, something got said before anyone else had a conversation, like a lot of things we've had to handle in the pandemic. It's unfortunate that 2 years in, we're still hitting the go button before we ask anybody if we're seated yet, and it just seems like here we are again. So, in Illinois, we're used to the insulin with $35. We know it hasn't been that helpful. We hopefully, maybe if it does get a national presence, that, that will make things easier. But we've got to start treating pharmacy like a healthcare profession, and we got to start getting remunerated appropriately before we allow Medicare to start negotiating. Because we allow Medicare to negotiate, we've already seen how they take the savings on our backs by allowing PBMs to basically scrape every bit out of our registers with DIR fees. We can't allow them to negotiate without having some protections in there for how that's going to impact pharmacies. So there's a lot of things that came out of the State of the Union. So just remember, those things are always about more of campaign promises than it is action. There were some action items at the State of the Union on foreign policy, but that's another issue. And so if you have questions on it, just contact the office. We'll tell you what we're hearing from the nationals. I know we'll be in a lot of discussions with APHA as we go forward on this, and NCPA as we try to navigate the curves of these programs after, sometimes they've left the barn and we got to catch up. So any questions or comments for this month's town hall? All right, everybody. Remember, if you especially that CE part, don't let it get past March 31st on your CE. Do we need any communication with Congress? Harry, you're right. Thank you. Thank you. Yes, we will be sending out a reminder. Those of you who have not submitted your statements to your federal U.S. senators and Congress representatives, to make sure that we talk to them about DIR fees, and to submit your comments also to CMS on DIR as well. We've also going to be having some additional statements for FTC coming up probably in the next month on PBMs as well. As you know, there was a discussion about that in this past month. The vote ended up being tied, so they didn't end up enacting a recommendation to open up a full study of the PBMs. That was very disheartening. It seems like there's a lot more going on. I highly recommend looking at the Politico article. It talks about how an economist for the FTC basically gave their resignation the day before because of back behind the scenes issues that was going on. So there's a lot more going on there than what we're hearing about. So, but they need to hear from us. They need to hear from you about how PBMs are systematically destroying the profession. And it's affecting everybody. And if you've lost your technician hours over the last 5 to 10 years, if you are continuing to continue to have volumes of work to do and not enough staff, it's because of PBMs. And so don't think that this is just an independent rural community issue. It's an all pharmacy issue. And we need everyone's help to get it, because it's going to take all of us to win. All right, everyone, and thank you to all of you who participated in Virtual Pharmacy Week over this past week. We were able to get about half of you, I think, in an appointment. So that was not bad. Working with our legislators and trying to work with them virtually. Hopefully, this is the last time we have to do a virtual legislative day. I like to have the numbers of 300 plus of you in white coats in Springfield. That's a lot better sight. And we do know it's noticed. So we will expect you next spring. And Laura, I saw that your hand was up, so go right ahead.
I'm just going to embarrass my Roosevelt students who are here tonight. Hi, guys. Thanks for being here. Okay, that's it. So happy and proud.
All right. Well, thank you, everyone. Have a great evening, and we'll see you next month.